Up next is Dr. Andrew Ringer, and he will be talking about memory and cognition after aneurysm treatment.
Hi, everybody.
Nice to have you here.
Great. And nice to be here. Thanks for inviting me. Let's see. Can you see my screen okay there?
Yes. Yep.
Great. So first of all, I'd just like to say, John, thank you for your comments. Those were really true, and it's really encouraging to hear somebody talk about their experience in such an uplifting way. It's a real example for a lot of people who struggle with their recovery. So we're really blessed to have you there as support for them and as guidance to us, the physicians, the treaters, the providers who do some of that support. We really need to hear that from you. So thank you for that. And you're right, we are, after all, Dr. Shirani, Dr. Grossman, Dr. Smith and I, Dr. Hodes and I, we're basically plumbers. We plug leaks and we open clogs. That's our job. So it's very true, and you understand it quite well. So, and also I thank the other presenters. They've had some really great talks today. You heard a lot early on from Dr. Hodes, Grossman, and Shirani about kind of, how we do it, so to speak. And then Dr. Smith and I think are kind of both talking about a little bit about the why we do it and what we do afterwards. So I think that was a great talk. And then Dr. Smith on all the trouble people have with headaches afterwards. This is a very, very common and often disabling problem that many of our patients suffer after rupturing a brain aneurysm. But one of the other things that we hear commonly is that I'm just not thinking like I used to. My memory's not as good. I'm not quite as quick with the taxes or balancing my checkbook or whatever. Some of these little things just seem to be not quite right. And that is a common phenomenon. So we're going to talk a little bit about that today and discuss why that happens, how we can influence how badly that happens and its recovery, and then they'll kind of finish up the talk with a little bit about what you can do to help yourself. So first of all, I don't really have any relevant disclosures. While I have served as a consultant for a number of companies that make the devices we use in the past, I really haven't done anything for a number of years to earn any money on that. But I do actively participate in a research group known as the Endovascular Neurosurgery Research Group. I'll be discussing some of the findings from several of those members as we move on through the talk. So when we start off, we're going to talk and focus a little bit on unruptured aneurysms. So those patients who come to us whose aneurysm has been identified because we're looking for something else. They had an unusual headache. It did turn out not to be a hemorrhage, but lo and behold, when we do the scan, we find the aneurysm, or we're doing a scan for some other reason, and it shows up. So who among those patients is really at risk for having a rupture? What's the risk if we were to decide to treat it? And therefore, when you understand those two risks, you try to decide, well, who really should be treated and who shouldn't be. After all, if the cure is worse than the disease, you don't want to undergo any kind of unnecessary treatment. And there are a lot of different features that we consider about aneurysms when we're trying to estimate your personal risk that the aneurysm may rupture in your lifetime. Among the most important of those features that comes from some of the best done clinical scientific studies are the size and location of the aneurysm, where we recognize that small aneurysms, which we define as those less than 7 millimeters in size, are less likely to rupture than large aneurysms, which are 12 millimeters or more, 7 to 12 being kind of that middle zone. And aneurysms that are on the arteries feeding the front of the brain seem to be less likely to rupture than those on the arteries feeding the back of the brain. So we will look at these features of your aneurysm as well as a couple of other kind of nuanced things about the anatomy of the aneurysm. And then we'll look at some of the medical risk factors in that individual patient to estimate the risk of rupture per year and therefore over your expected lifetime. And then the next piece of arithmetic that needs to go into it is what would be the risk of a problem if we tried to fix the aneurysm? What are the risks that you may have some complication or new disability or problem or difficulty after treatment? And you've heard a little bit about how some of the treatments are done. As we mentioned before, there are really two main categories for treatment. There's the open surgical treatment or clipping that we refer to, and then there's the inside the artery approach with multiple different devices. We usually call it coiling because that was the first and most common tool that we use, but as Dr. Shirani pointed out, we've got a lot of different tools now So that's sort of just part of our nomenclature, if you will. But endovascular, inside the artery, and craniotomy or surgical for the clipping, those are the ways that we treat aneurysms. The goal is ultimately the same in any treatment that we do, and that is to try to stop blood from flowing into the aneurysm so that it can't grow or rupture, but without interrupting the normal blood flow in the artery that's feeding the brain. So ultimately, we're trying to accomplish the same thing. It's just a different way of doing it. If you look at the surgical clipping, there are some pretty big advantages here. Among them is that it's almost always a one-time deal, lifetime cure for that aneurysm. Better than 95% lifetime guarantee that you will not see that aneurysm, any part of it, even if we went back and looked for it, and better than 99% lifetime guarantee that it won't bleed. That's about as close as you can get to a guarantee in medicine. However, we have to open your head and touch your brain and get down to the arteries in order to do that. So there are certain risks associated with that. And one study that looked at new cognitive or memory type of disability after a craniotomy for surgery has found that was highly related to the age of the patient. It was about 5 or 6% for young patients under the age of 45, went up to about 15 or 16% for those patients between 45 and 65, but could be as high as 30% for patients over the age of 65, depending on the size and location of the aneurysm. So obviously, for some situations, that's not a tolerable risk, and we wouldn't want to undergo that kind of risk for treatment if we didn't think that the aneurysm was very risky. Coiling has a couple of advantages. It's less invasive. I don't have to open your head or touch your brain in order to get there. It's a faster recovery, so you get back to your normal activities much quicker. However, a small percentage of people will have some shifting of those coils. I like to refer to it as the garbage compactor effect. Blood pulsates up against those coils, packs it in like garbage in a garbage compactor, and now there's some empty space in the aneurysm that allows blood flow to get back in. And you can't feel that happening. So we make our patients come back to get scans, and in our practice, we do an angiogram at 6, 12, and 24 months to check and make sure that's not happening to you. And then after that, we go on to MRI or CTA, non-invasive studies, for 3 more years. So we have to watch the aneurysm for 5 years. You don't really have to do that with the surgery. And a smaller percentage, not all of those patients who have that garbage compactor effect will have to be treated again. If it's a small amount, we don't really care, but if it's really significant, you might actually have to have a second treatment, and that's very uncommon with the open surgery. So that's a potential disadvantage for the coiling. Now, there is a third option, and that is to do nothing. Just watch it. Leave it alone. Don't treat it. Accept the risk of the aneurysm. If we believe that that risk is low and therefore lower than the risk of treatment, then we may just observe it. And we observe it in part because there's other data, a little bit less scientific, but still fairly reliable, that says that if you see any kind of growth in the aneurysm, like Dr. Hody showed us earlier this morning, that the risk of that aneurysm rupturing now dramatically higher. That risk may go up by more than 100-fold. Some studies estimate between 10 and 18% in just 1 year. So that's a big, big risk. Now the math is very, very different, and it becomes worth treating it. But we don't know if it's growing if we don't look. So again, we have a protocol for doing this. We look every 6 months for 2 years. And then if we haven't seen growth in the first 2 years, we back off and do it just once a year for 3 more years. And then if it's been stable for 5 years, depending on the age of the patient, we may check every 5 years up to the age of 70 or so. But after the age of 70, the risk of treatments becomes so much higher that we don't even bother looking after that time. So there are all these different ways that you can manage these aneurysms, and in doing so, take into consideration the risks of some of these new disabilities that the patient might have, either from rupture of the aneurysm or from the complication of treatment. What we have noticed, and as Dr. Sharani pointed out so well, there's been a lot of technical advances in how we treat aneurysms over the past several years that has made our treatments safer. So fortunately, what that means is we can now treat more and more patients with unruptured aneurysms safely and treat them to prevent that hemorrhage from ever happening in the first place. Fewer complications and fewer difficulties. But here's the problem. If you look at most clinical studies and try to understand how patients do after their treatment or after their hemorrhage or after whatever event might be, we don't do a very good job of reporting some of these more subtle problems. The I'm not thinking quite so fast problem, the I can't remember everything problem, the I just walked in the kitchen, I don't know why I'm in there kind of problem. That stuff doesn't fall out in most of the outcomes that we use. We've not done a very good job of doing that. Our studies typically look more at just basically the gross function and daily activities, and don't take into consideration some of these other subtle things. So some of the patients who in the literature that we read are reported as having a very good outcome, if you ask them, they might not think it's so good because they have these other difficulties and disabilities. And here's why. There's one of the most common scales that we use to report the patient's outcomes is the modified Rankin scale, which you see here on the screen in front of you. But I want to call to your attention this moderate disability level, the level 3. That's the patient who can still walk on their own, and they can still get around on their own, but they need a little bit of help with their most of their daily activities. Well, that means they can't do their own grocery shopping. They maybe aren't safe in the kitchen. They can't, plan their travel for vacation with their family. Somebody else has got to do it because they're going to screw it up. And that is a disability. Honestly, that is really adversely affects one's ability to function. Certainly, it affects your ability to hold down a job, to run a household without some help. I mean, it can really change your life to have that. And yet, 0, 1, and 2 is considered a very good outcome. 3 is a moderately okay outcome. It's only the other ones that are considered really poorly disabled on most clinical studies. So this is so much true that some publishers, some writers have and clinicians have looked at this to see what is the real true disability among patients who are reported as having a good outcome. So it's a real thing out there that these patients who are quote unquote good after their procedure or after their aneurysm hemorrhage may not actually be as good as we think. So let's talk about what are some of the consequences of treatment of aneurysms or of an aneurysm hemorrhage. So we're talking about one's ability to maintain intention or concentration, your visual spatial skills, ability to understand depth perception and relationship of objects. We call that apraxia. Difficulties in perception, cognitive processing, executive function, language and word finding difficulties, behavioral and mood control problems. So a lot of times patients after an aneurysm hemorrhage may find themselves really highly emotional and they don't understand why. They can't control the way they express themselves, and they have a very difficult time coming up with some of the language that they want that would be really articulate what they're thinking or feeling. So these are some of the skill sets that we don't do such a great job of evaluating in most clinical studies and clinical situations. So how did that all happen? How did these kinds of new disabilities occur? Well, one is by aneurysm rupture. That's an easy one. Patients who rupture their aneurysm often have lots of different forms of disability that they have to contend with, even if they are the good survivors that I mentioned before. Interestingly, though, some of the risk factors for having an aneurysm in the first place, well, they might also impair your cognitive function a little bit. We're going to talk about that in a couple of slides here also. And finally, there may be a difference in outcome depending on the type of treatment that you have. And that's something that has to enter into the discussion when we're talking about how to treat aneurysms and we have the opportunity to make that decision. So first of all, aneurysm rupture. Up to 40% of patients who rupture an aneurysm will die, many of them before they even make it to a hospital. And among the people who survive, a majority of them will have a permanent significant disability afterwards. I mean, it is a big, big deal. So it is not at all surprising that the patients, even the patients who make what we call a good recovery, where they're able to take care of themselves, dress themselves, feed themselves, even drive themselves to the office for follow-up visits, may still not be quite as good as they were before. They might not be able to still do the job that they had before. They may not be able to run their household on their own. They may just need help with some of these things. So that's not unusual. There've been a couple of interesting studies also that look at some of these risk factors. We've said it a million times to many of our patients that have aneurysms that we know there are certain types of risk factors that may increase your risk of having or rupturing an aneurysm, which include things like uncontrolled high blood pressure and smoking, that you can control. That if you manage these things, you can reduce your risk of rupturing the aneurysm. Well, as it turns out, you might also reduce your risk of having cognitive problems. In this particular study, they looked at cognitive function of patients with an unruptured intracranial aneurysm over time and compared it to non-aneurysm patients with normal cognitive function. So that black bar is normal cognitive function over time. And what they found was patients who have aneurysms actually start to show a little dip in their cognitive function even before they undergo any kind of treatment. They take another hit after they've been treated and recover from it. But look at that drop in cognitive function before you've ever had any intervention or surgery or anything. That's probably a consequence of some of the other medical risk factors that are going on that led to having the aneurysm in the first place. These are some of the things you can control. Having your blood pressure checked and treated if it's too high. If you smoke, give it up. Do whatever you have to stop smoking, because those will be very important risk factors for you to control. And that's something that you can impact. They'll have a positive impact on yourself. And then finally, what are the differences in cognitive outcomes after treatment of the aneurysm based on the type of treatment that you have? One of the studies that we quote so very often, including the one that and this is the one that I quoted earlier, excuse me, that talked about the size and location of the aneurysms associated with the risk of rupture. In that same study, they observed patients who underwent treatment and evaluated them at 30 days and 1 year after treatment to see how they were doing. And this kind of complicated table shows that, where we have the open surgical over here to the left and the endovascular patients over here to the right. Ignore the group 1 and group 2 for the time being. That's not important for our conversation, but I want to call to your attention these rows of data that look at the impaired cognitive status only. So these are not patients who had that modified Rankin problem. They're still, according to the modified Rankin, they're still a 0, 1, or a 2, a very good outcome, but they have impaired cognitive function. And that, as you can see, between roughly 5 and 7% for most treatments, maybe a smidge higher early on with the surgical treatment than with the endovascular treatment, but that gap closes over time. But that's not insignificant. That's 1 out of 14 people. So 1 out of 14 people who has treatment for an unruptured aneurysm may have cognitive disability afterwards. So that's a not insignificant problem. So here's where some of my energy colleagues come into play, and a few of them, good friends of mine and very astute clinicians have looked at some of these kinds of problems. So Aditya Pandey, who's one of the endovascular neurosurgeons, so he does both the clipping and the coiling like I do. He's at the University of Michigan. He looked, and his group looked at a group of patients who were undergoing elective treatment for aneurysms. They took 40 patients who were having coiling, or endovascular treatment, 40 patients who were having surgical clipping, and took another 40 patients who are of the same age and gender and general medical risk profile, but didn't have aneurysms. And they went through a very rigorous fine motor, cognitive function, memory, and executive functioning testing that they checked at baseline before treatment, 2 weeks, 3 months, 6 months, and 1 year after treatment. And they looked at that and looked to see, first of all, what are some of the big complications that occur afterwards, after surgery, like having the aneurysm rupture during surgery, having a stroke that caused some symptoms, having problems with some of the nerves that are around the aneurysms, the ones that move your eyes or help with facial movement or speech. And they compared those differences. And then they put the patients through these cognitive tests. So here's some of the testing that they did. They did a auditory verbal learning test where they would repeat a series of 15 words. Then they kind of pepper that with 15 other words that weren't part of the list, and then asked you to remember the 15 that were on the list. They put together a very complex geometric structure and asked you to draw it from memory. You don't get to do it with a picture right next to you. You have to try to remember it and draw it out. And then fine motor skills were tested using your non-dominant hands. If you're right-handed, you have to take these little pegs up with your left hand. You have to turn them to match that key configuration that you see there on the pegboard and get them to fit inside. And they want to see how quickly you can get the board filled in. And then they try to trip you up with a little bit of stuff. So this is a great one. You look at the series of words over there to the right. You are asked to look at that and tell me the color of the word, not the word itself. So that first word, for example, the correct answer is green, not yellow, because you're supposed to look at that and do it as quickly as possible. They want to see how fast and how many of those words you can get correct. So if you have to stop and think about it a little bit longer, you score more poorly. Then they'll also have you do a number of executive function tests where you have to look at the order of words and try to connect numbers and symbols together. You do mathematics using symbols that replace the numbers. You have to try to remember what the symbols are and turn them into numbers to do the math and try to figure it out. So these are all really higher cognitive function tests. So what were the results? They looked at these patients, and again, you'll notice here, the black is the non-aneurysm patients, the green is the ones who had the endovascular or the coiling treatment, and the red is the open surgical treatment. And again, our patients with aneurysms were functioning a little bit less well at baseline than the normal control patients were, perhaps because of those risk factors we talked about. And then they have their treatment, and each group underwent a little bit of a hit, but the surgical group had more of a hit and more of a decrease in their memory than the endovascular group. However, by 3 to 6 months, they started making it up, and after a year, those differences essentially went away. If you look at fine motor function, for whatever reason, some of the endovascular patients just weren't as good with their fine motor skills. We don't know why they started off that way. But they kind of stayed level. The surgical patients, they took a little bit of a hit right after the surgery, but they gained it back within about 3 months again. And likewise, when you look at that higher cognitive executive functioning and processing speed testing, the endovascular patients really didn't have any new problems afterwards at all. They kind of stayed level. The surgical patients, once more, took a bit of a hit, but within about 3 to 6 months started regaining that function and closed the gap. So really what this tells us is that the surgical exposure might cause patients to have a little bit more trouble early on, but that is recoverable over time. Now, there is an unintended complicating feature here, and that is that based on the way they did their practice, patients with aneurysms on the part of the circle of Willis called the anterior communicating artery, it's up here in the front between the two halves of the brain, right under the frontal lobes, was more likely to get the surgical clipping in their practice than the endovascular coiling. We know that the frontal lobes, which we have to touch and move to get to that artery, are really important for cognitive function and memory. So could it be that we just chose the wrong patients to have the surgery? There was a big difference. So they did go back and look at their surgical patients, just the ones that had the open surgery, and compared the patients who had the aneurysm up there in the front and all other aneurysms. And what they found was that all of them, yes, did take a bit of a hit, but the anterior communicating artery aneurysm patients took maybe a little bit more of a hit in their memory than the other aneurysm patients did. When it came to fine motor function, clearly a difference between the two, where the anterior communicating artery patients here took a dip at the 2 weeks, whereas the other aneurysm patients didn't. They sloped up. That's probably just a learning effect of the test, getting to practice it over and over again. And again, with executive function, the light teal here compared to the darker teal is the anterior communicating aneurysms, and they took more of a hit than did the other aneurysms. So the aneurysms under the front of the brain, that anterior communicating artery, might be a little bit more prone to some of these cognitive disabilities, particularly after surgical treatment. So ultimately what they concluded was that memory and executive function or processing speed does seem to decline more so after open surgery than after endovascular coiling, but that recovers in about 3 to 6 months. And for whatever reason, that as we saw in that motor test, the endovascular patients didn't have quite as much learning effect as the other patients did. But who's going to do all that? I mean, that was a whole lot of testing. Can we really do that for all of our patients as they're coming through for aneurysm or stroke treatments and still fit it into our schedules? After all, you're already noticing probably that when you come in to see us, we're often running behind because we pack our schedules really tightly to try to get as many people in as we can so that we don't miss anybody. The physicians and the nurses just often don't have time to do that degree of testing on every visit. And same thing for our patients. You don't want to come in for your doctor's office and end up spending 2.5 hours there instead of just 1 hour. You've got to get on with your other things, your life, and get out of the office. So there may be some other tools that can do the same kind of thing and provide that same sort of input for us. So one of them is the Montreal Cognitive Assessment Test, or the Mocha. This study, it takes about 5 to 10 minutes to deliver in the office. It has to be supervised by somebody who administers the test to the patient. But it's being used by another one of my energy colleagues and friends, Rob James, who's not at University of Louisville anymore. He moved to Indiana University just recently, so I got to update that slide. Sorry, Rob. But his study, the ASTRO study, was looking specifically at cognitive function after subarachnoid hemorrhage and whether or not certain medical interventions could improve it, but this is how they wanted to test it to evaluate those patients' functional standing before and afterwards. What a lot of the other members of that study group, the energy group, have decided to do is try to make this testing part of our standard clinical practice. Add the extra 5 to 10 minutes to each office visit for patients at baseline, right after their intervention for whatever we're treating, and a little bit later on down the line. And one of them, Clement Shermer, who's at Geisinger Health in Pennsylvania, he actually wants to look at that cognitive functioning and see, does that influence, does it help improve rather the way we make our decisions? Does it help the clinical team, the patient and the doctor and the nurses figure out what is really the best option for that particular patient? So he's looking at all of these other complicated features that come into play when the patient comes into the office that may influence what we decide to do for that particular aneurysm. And they want to look at this to say, did we do a good job? For example, if the doctor is recommending that we treat the aneurysm, does the patient also feel like they've got a preference for treating it? Is there an agreement there? Conversely, do they both agree that no, we shouldn't treat this aneurysm, we should just watch it? Is there concordance on the decision, and how confident is everybody in that shared decision? As opposed to what you see on the matrix here, blocks B and C, is where there's some disagreement between the preferences of the physician and the patient. So we're going to go and look at a little bit how we test that. There are a couple of tests that we use. One is called the SURE test, which is an acronym. The S stands for how sure are you that the choice you made was right for you? Did you understand all of the risks and benefits of that, of the options that were presented to you? Were you clear about those risks and benefits, and which ones were most applicable to you in particular? And do you have enough encouragement or support and advice to make that decision and feel confident in that decision? And so it's a very simple 4-point scale that the patient answers to let us know whether or not they are really confident that they made the right decision. And there's another scale or questionnaire that's used called the decision regret scale. How once you've gone through your treatment, were you happy with the decision? Do you strongly agree that it was the right decision and the right path for you? Or do you kind of think, maybe I wish I'd have done something differently? So this is a way of testing before and after the treatment. How confident is the patient that they made a really good decision, and does that last? Does that persist after treatment? And then you can compare that to the patient's cognitive functional outcome. And it turns out when Rob James looked, for example, at the cognitive function as a function of the patient's overall recovery, there seemed to be a bit of a difference between men and women, but the recovery still, the cognitive function could still be an independent outcome compared to modified Rankin. And what Clem is finding is that the sure and regret scales are not necessarily a function of the patient's cognitive function. In other words, the patient who has more cognitive disability might still have the same likelihood of feeling confident that they made the right or wrong decision as a patient who does not have cognitive disability. So these are real tools that help us to understand whether or not we're making the right advice for the patient. So it helps teach us as clinicians how to communicate better with our patients about the risk factors, the options, and the available treatments to them. So I just want to give a quick shout out to the members of that study group, the Endovascular Neurosurgery Research Group. If you're not here in the Cincinnati area, or you know somebody who's in another community, I have good friends and colleagues who I trust, who are very careful and caring physicians who are part of all this study all across the country. So please let me know. I'd be happy to help you find one of those really good doctors out there to take care of your loved ones. So now let's talk a little bit about what's your role in this. What are the things that you can do that might help to improve your cognitive function, or at least prevent it from deteriorating further? And we talked a lot about some of these risk factors. So I'm going to say it again. Smoking. You've got to quit smoking. If you are smoking, you are harming yourself, and no one else to blame for that than you. So whatever you need to do, whether it is to get hypnosis or acupuncture or try medications, or just lock yourself in a room for a weekend and go cold turkey, whatever it's going to work for you, I want you to do it. And keep in mind, trying once and then falling off the wagon and starting to smoke again, that's not a failure. Think of all the cigarettes you didn't smoke during that time frame. That's a win. So just do it again. Do whatever you have to try. Try something different the next time if you need to, but whatever it takes, please quit smoking. Monitor your blood pressure. Check it frequently. Check it at your doctor's office. Check it when you go to the Kroger's. If you notice that it's running high, and by that we mean the top number is higher than 140, the bottom number is higher than 90. Some people would say the top number should be down around 130 or lower even these days. Then talk to your doctor about things you can do to control your blood pressure. You might not need medications. It might just be a healthier lifestyle that helps you bring the blood pressure down. But whatever you do, bring it down, because that is what we call the silent killer. It's eating away at your brain and at your heart and other vital organs little by little over the years. Alcohol consumption. Having a little bit of alcohol is not necessarily a bad thing. In fact, a lot of studies would argue that very moderate drinkers, people who have no more than 1, maybe 2 drinks a day, down to as much as just as little, I should say, as like 1 or 2 drinks a month. People who drink that little actually survive longer than teetotalers who never drink at all. However, that's a slippery slope, because as soon as you get to 2 drinks a day or more, and you're getting a little bit higher than that, then it's a dramatic decrease in the other direction. And we have to understand what is exactly a drink. We're talking about 12 ounces of standard alcohol beer, that's like 5.2 or 5.5% alcohol. 5 ounces of wine. So keep in mind, in a bottle of wine, there are 5 servings, not 4. So you don't get to each, you and your spouse don't each get to have 1 pour out of that. That's 2.5 servings for each of you if you do that. And 1.5 ounce of 80 proof liquor. That's a single shot. So that's what we mean by a serving. So if you're going to your favorite bartender and they're giving you the extra little pour, that's not 1 drink anymore. That's a little bit more than that. So please keep that in mind. And then finally, something about your diet. This is actually a very interesting area of research that's gone into over the past several years. And these are long observational studies for many years, where they look at patients who eat specific kinds of diets. And so this one, the MIND diet, has known association with improved cognitive outcome or improved function long-term over other standard diets. So it's a combination of the Mediterranean and the DISH diet. And in general, what they do is they list 10 brain-friendly foods that you see listed here: the green leafy vegetables, non-starchy vegetables, berries, nuts, olive oil, whole grains, etc. And they're asking you to limit then 5 foods that are a little bit potentially harmful for you: butter or margarine, cheese, red meat, any fried foods, sweets, or pastries. So eat a lot of the 10 good foods, eat as little as you can of the 5 potentially harmful foods. And the goal is to kind of keep that balance on the healthy side. And the more you do that, the more you're helping yourself, keeping your brain active, healthy, and functioning well. And then finally, another great study that was done over many years. This is a 20 to 25 year observational study. Looked at patients who underwent regular exercise to those who didn't, and noticed an improved cognitive outcome or function for those patients who were regular exercisers. So they checked the fitness of 2,700 people. They checked them again 20 years later to see who had been staying active and staying healthy and exercising regularly. And they found that the patients who kept themselves physically active and healthy with regular exercise scored 10% better on memory and cognitive function tests than patients who didn't. So eating right, controlling your risk factors, getting regular exercise, those are the things that you can do to help improve your cognitive function long term. So I'm going to stop there. I don't know if I did well on my time, if I went over my time, but I covered a lot of ground there. So if there are any questions, please let me know, and I'll be happy to answer them.
Thank you, Dr. Ringer. We do have several questions, so I will get right into it. The first one is, would the cognitive deficits start immediately after the bleed/surgery, or could they start years later without any new insults?
So I would say what we saw in the studies there is that almost always the ones associated with the hemorrhage or with the procedure happen immediately after that event. If an individual is noticing decline in cognitive function many years later, now we may be looking at some of these other risk factors or modifiable things that we're talking about. If they're profound, if we're seeing really significant cognitive decline, it is worthwhile to talk to your doctor about that, perhaps see a medical neurologist and have some testing done to see, is it a degenerative process? Is there something else going on that's contributing to some of that cognitive decline?
Thank you. Kind of related is, if I already have memory problems, am I more prone to get dementia when I get older? Are they related at all?
So that's a complicated question. They're not really related. However, if we acknowledge that that there's a little bit of cognitive decline that happens with normal aging anyway, it's more accelerated and pathologically so in the cases of Alzheimer's and other true dementia cases. But if you're starting off at a level of function here, you're not going to do as well as if you're starting off at a level of function here. So that decline is going to come from your starting point. So if you already have some cognitive issues, then it's all the more important, I think, that you pay attention to those things that you can control that we've just listed and do everything you can to maintain a regular, healthy lifestyle. It's worth noting also that some of the other things that tests on aged patients would suggest is that learning something new does help improve cognitive function. So if you're retired and looking for things to do, learn a new language. Take a class on new language. Learn how to play the piano if you didn't know how to play it before. Anything like that that requires your concentration and effort is going to help stimulate that cognitive function and keep it active. Okay.
What about caffeine? Is caffeine okay?
Yeah, well, somebody saw me picking my coffee cup there a minute ago, probably, but I am very happy to report as a regular coffee drinker that so far we have not found any significant health detriments to regular coffee drinking. And now the caveat here is to my knowledge, most of those studies have not really categorized heavy caffeine intake beyond 4 cups a day. So 4 cups of coffee is kind of considered the high level. Some of us have more than that. But at least up to 4 cups a day does not seem to be associated with any decrease in cognitive function. In fact, some suggest that regular coffee drinkers are less likely to develop dementia or age-related cognitive decline than non-coffee drinkers. The other caveat is this may not apply to people who have heart rhythm problems, what we call arrhythmias, and other things that can be stimulated or aggravated by excessive caffeine intake. So please be careful about that. You know, if you're thinking about becoming a heavy coffee drinker, talk to your doctor about it beforehand. Just make sure you don't have some other risk factors that could be a complicating factor.
Sure. Thanks. Is it easier to get angry after surgery?
Yeah, so that's part of what we were talking about with when I mentioned the emotional control. And we see that for patients who have had aneurysm ruptures also, these personality changes in the ability to control one's emotions or to express them in a socially appropriate way. Interestingly, it can go either direction. I've had patients who are just sweet and kind and peaceful beforehand who become just raging monsters afterwards, at least temporarily, after an aneurysm rupture. And I've had other people who said, oh yeah, so-and-so was a real SOB beforehand, but ever since his aneurysm rupture, he's kind of nice. He's kind of quiet. Wow. So these do happen. It can happen either way. I don't have a good explanation for that necessarily, but one's ability to control your emotions and to express them in a socially appropriate way is, well, without question, can be compromised by an aneurysm rupture or by an insult from intervention.
Okay. That makes sense. Could some of the cognitive issues in older patients be linked to anesthesia issues? Post-treatment for the first year, I was carefully watching for this while working every day. It seemed to get better within 3 months or so. Hangover versus invasive surgery, ?
So that's a multi-layered question. I think I understand it. But so the phenomena it sounds like you're describing is similar to what we saw in Dr. Pandy's study, where initially right off after an intervention, there's a dip in your cognitive function and your processing speed. It recovers after about 3 to 6 months, and at least within a year seems to return to baseline. So that sounds pretty typical, I think, of many patients' experience.
The question about anesthesia does come up, and I've heard Dr. Sharani talk about that as well, about the preference for using general anesthesia when we're doing interventions. And that's a debate, honestly, that physicians don't all necessarily agree with. If we're looking outside of aneurysms at ischemic stroke, for example, ischemic stroke interventions, one of our former fellows, Dr. Nichols, was looking at this as well, and some other researchers found that use of general anesthesia for stroke emergencies actually reduced the patient's recovery. So there does appear to be a little bit of a hit that happens with general anesthetic in some cases. Now, that's a different disease process than the aneurysms, and the technical demands on that procedure are maybe not quite as nuanced as they are for aneurysm treatments. So hence the debate rages as to whether or not anesthesia is good or bad.
Okay, I think we'll have one more question and then we'll move on. But this one says that I saw some research articles which discuss the high incidence of post-traumatic stress disorder in subarachnoid hemorrhage survivors. Even after 3 years, 25% met the diagnostic criteria for PTSD, and this includes patients who have recovered well physically. Since avoidance of trauma reminders is a common symptom of PTSD, this could deter patients from showing up for follow-up angiograms, scans, and appointments, as these things can trigger PTSD. Have you seen this in your practice?
Yeah, so I guess I haven't necessarily quantified it or characterized it as PTSD per se. There's no question that sometimes there's an educational component that's required of us for our patients who associate their difficulties with the hospital stay or with their procedure, when in fact it really was related to the rupture of the aneurysm. And when we help to educate our patients to understand that all the horrible headaches you've been having, the memory loss that you had, the fear that your family had that they may lose you, all that happened because the aneurysm ruptured, not because you had the aneurysm treated after it ruptured. And the goal of having people come back for continuous care is to make sure that they're not at risk for that happening again. So I think that taking that a little bit of extra time to kind of really divorce the disease from the treatment and help the patient understand that the follow-up is really part of that treatment that helps prevent another ever having to go through that again, usually is quite effective for most patients. But you're right, there is a fear factor there that requires a good relationship between you and your doctor.
Sounds good. Thank you for your time, Dr. Ringer. I hope you have a good rest of your Saturday.